Hi, everyone. Thank you so much for joining. My name is Ashley Arkema, and I'm the nurse practitioner in the Female Sexual Medicine and Women's Health Clinic at Memorial Sloan Kettering Cancer Center. I'm going to go ahead and get started. I'm going to talk to you today about some of the sexual side effects from treatment and remedies to mitigate these side effects. I'm also going to talk a little bit about communication with your partner and also about hot flashes. And I wanted to just say I'm really grateful to one of our fertility nurse specialists who spoke with me and shared some of her slides. I work in the sexual function clinic, and we have a separate fertility preservation program. And I'm really grateful to her for sharing those slides with me, which I'll share with you. I'm hoping one of them can be available during the Q&A session. And if not, then I'd be happy to take your questions and then get back to you at a later time with the answers. Sexual dysfunction is a broad term that includes difficulty with sexual interest or libido, problems with arousal or orgasm, and also sometimes vaginal dryness or pain with intercourse or sexual activity. There's various causes for sexual dysfunction, and hormone deprivation from chemo and radiation is one of the primary causes. So there's a drastic change in hormone levels. There can also be fatigue and stress related to cancer treatment or general anxiety that can affect interest in sex, body image issues and infertility, and then partner issues, whether it's communication or issues in the relationship or partner sexual dysfunction as well. There's common sexual and vaginal health changes that happen after cancer treatment, and these can include vaginal dryness or irritation, loss of desire or interest, which we talked about, and difficulty with arousal, and pain with sexual activity or with just general GYN exams can also be a problem. I would suggest getting started on some of these before you develop symptoms. So before you start to feel symptoms of dryness or irritation, it's important to start using something called a vaginal moisturizer. And there's several different examples of this. I have no disclosures. I don't work for any of the brand companies, but I wanted to just mention some different products that you can use that may be helpful. So moisturizers are used on a regular basis, typically 3 to 4 times a week at bedtime. And they're used inside the vagina and can also be used externally at the vaginal opening and around the clitoris. And some examples of these are Replens, Reverie, and Halogen. A lot of patients that I see really like Reverie because it's a suppository, so it's very easy to use and not messy. Some of the other products are creams or gels, but you really have to play around and see what's best for you. If you've given these a good 2 to 3 months and you're still not noting improvement, then I would talk to your gynecologist about a low dose of vaginal estrogen. And vaginal estrogens, I know that hormone treatment can be sort of a scary thing to do, but vaginal estrogens are very low doses. They stay in the vagina. They're minimal absorption in the bloodstream. So there's very few contraindications for the use, and there's very few risks with vaginal estrogen. So most people are candidates to take it. Lubricants are used with sexual activity, and this should be with external or penetration. There are multiple different options. So there are water-based lubricants. I listed some examples. And then there's also silicone and oils. So the silicone and oils are going to last a little bit longer and be more slippery. One thing about oils is that you don't want to use those with condoms because they can degrade the condom. It's also good to be aware of ingredients. So propylene glycol, glycerin, sometimes chlorhexidine is in over-the-counter lubricants. So I would check the ingredients and then always avoid any warming, tingling, or flavored products that can also be irritating to the vaginal mucous membrane. Vaginal dilators are given to patients after radiation treatment to prevent narrowing and scarring of the vaginal canal. And it's very, very important to use these at least 3 times a week for about 10 minutes, rotating for width and for length. They're not fun to use. It's very difficult to maintain this, but it is so helpful. And you really see a difference in people that have stuck with the vaginal dilators versus those who have not. The other thing is that many radiation oncologists will actually have patients insert a dilator during treatment. So this is to help protect the vagina and the vulva from the radiation field. So if you have not had treatment yet, I would definitely inquire and talk to your radiation oncologist about that. Pelvic floor physical therapy is a very useful tool for our patients. And I usually refer almost everyone that has had pelvic radiation to pelvic PT if possible. Pelvic floor dysfunction is very common in the general population. So it's about 30% or more of women deal with pelvic floor issues. And this is going to be exacerbated from radiation treatment and menopause. The symptoms can include a variety of things. It can be sexual pain or problems with urinating or with bowel movements. So if there's any leakage of urine or stool, it's definitely something that can be helpful for that. So I would definitely inquire about a referral for a pelvic PT from your doctor. Low libido or diminished interest in sex is really common in individuals going through cancer treatment. And the biggest thing I can stress here is addressing the underlying cause. So there's often, it's multifactorial, but figuring out sort of what's the root cause. Are there relationship issues? Are you not sleeping? Are you feeling fatigued and tired? Then you're not going to want to engage in sex. Also pain. So some people feel like they're not interested, but they're having pain. And they say to me that if the pain was gone, they would be more interested. So first step would be addressing the pain. Couples counseling and sex therapy can be very, very helpful, especially having a third party to kind of help navigate these issues. And I would really encourage you to, there's a website, an organization called ASECT, and you can actually search for a counselor in your area. Bupropion, so this is one medication. There's very few medications for low libido in women, unfortunately, but bupropion is a FDA-approved antidepressant drug, but there's been some new emerging data that it may also be helpful for cancer fatigue and for low libido in women. So I have sometimes given this off-label for that indication. So I would definitely inquire. Hot flashes. So hot flashes can happen as a result of menopause, and there's different treatments for this. The first thing we think of is hormone treatments or hormone replacement therapy, which can be controversial, but it is pretty safe if you don't have certain risk factors and you're of a certain age. I'm not going to go into detail about that, but you can definitely discuss this with your cancer clinicians and also with your gynecologist. There's non-pharmacologic or non-prescription treatment for hot flashes, and some of these options are mindfulness, weight loss, and acupuncture. Paced respirations are basically taking a deep breath in over 5 seconds and exhaling over 5 seconds. So by slowing down your breathing when you feel the onset of a hot flash, you are also slowing down your heart rate and reducing the hot flashes, the frequency and severity of them. Antidepressant medications are given sometimes another use for antidepressant drugs. Some of them can be an improvement in hot flashes. So this is people that may not be anxious or depressed, but they actually take a low dose of these drugs to help aid in the hot flash relief. And then there are drugs called, this oxybutynin is a drug for overactive bladder, and another indication, which has recently been found in some studies, has been that it's really useful for hot flashes. So some people will take that. Gabapentin is a drug that's often used for neuropathy or numbness and tingling after chemotherapy, but another use can be for hot flashes, particularly hot flashes that are occurring at night. Sometimes higher doses of gabapentin are required to relieve the nighttime hot flashes, and this can make you feel sleepy. So it tends to be better to take them at night or to use for people that are just getting them at nighttime. So I'm going to talk a little bit about fertility. So cancer treatment can affect fertility. And this is because of both chemotherapy and radiation. So like I mentioned before, it can age the ovaries and lead to earlier menopause. So depletion of ovarian follicles, it can happen from the chemotherapy treatment. And then with radiation treatment, that can also damage the ovaries and damage the uterus. So for the ideal time for people who want to do egg preservation or egg freezing is right when they're diagnosed or before beginning treatment. So you actually can go in to take hormones, and then you go into a fertility doctor and have a retrieval, and the eggs are frozen. Some patients will go on to pursue surrogacy and have someone carry the pregnancy with their own egg at a later time. And this just goes into egg preservation. So ovarian stimulation, like I mentioned, and retrieval, this is just a picture. Basically, a needle will go through the vagina. You're under anesthesia, and then they retrieve several of the eggs, and then freeze them for a period of time. The big downside to egg freezing is cost. And this sometimes is covered by insurance, but sometimes is not. And again, I hope one of the fertility specialists will be available to answer your questions. And if not, I'd be happy to answer what I can and then reach out to them. I want to thank you all so much for joining. And again, I hope this was helpful for you. Thanks so much for having me.
Hello, everyone. Thank you so much for having me today. My name is Samantha Strumeier. I'm a family nurse practitioner. I work at Memorial Sloan Kettering Cancer Center, and I specialize in men's sexual medicine. And I'm here today to talk to you about saving your sex life, some of the sexual implications that can occur after your anal cancer treatment. And I want to tell you how as a man, you can optimize your sexual function as best as possible. So our objectives today are to discuss some sexual side effects related to radiation, review some ED treatment options, explore some other risk factors that can cause erectile dysfunction, and I'll present a small bit on fertility as well. So as you know, radiation is one of the key treatments in anal cancer, and there are some specific side effects from radiation that can occur to the erectile tissue. For one, it's a very slow decline. So typically men don't say that they have the side effects immediately. They'll present 2 to 3 years later and say that they've noticed over time that their erectile function has steadily declined. And we relate it to the artery that's in the penis that tends to thin over time, not allowing for as much blood flow to go inside the penis. We also can relate it back to some nerve damage. Now, it's less damaging with anal cancer because the radiation is really in the back of the nerves as opposed to directly to the nerves, like in prostate cancer. But we do see some form of nerve damage as the radiation is not as specific as it can be. Now, the data is not perfect, and we know that the data in prostatectomy patients, so patients that have prostate cancer that receive radiation, they are at much higher risk of not being able to ejaculate. However, this could be a possible side effect of radiation, that you will not be able to ejaculate. So what are some options? Well, the first and foremost, it's always important to stretch the muscle of your penis. Your penis is a muscle that requires oxygen, just like all the other organs in the body. So the 3 major components are to get stretch, blood flow, and oxygenation. And to do that, if you're unable to spontaneously get erections on your own, there are some options for you. Your first line of treatment can be an oral PDE5 inhibitor, which is like Viagra or Cialis. There are specific ways that you will want to take Viagra. It needs to be on an empty stomach. So I highly encourage that if you do take these medications, you do research a little bit about the appropriate ways to take them. Alternative options, if the PDE5 inhibitor is not working, you can use a vacuum device. It's a little bit different in the sense that you have to pump your penis up with the device. It could be relatively expensive. And it does pull in venous blood flow. So it's not clean, oxygenated blood flow, but it will give you that sensation of having an erection and a technically real erection. Penile injections are typically the next step that we offer for men that aren't responding to PDE5 inhibitors. And the reason for that is because it's the true way to get a good erection, meaning it makes that artery dilate, open up, so that the blood flow can go inside the penis. Now, you may be saying, oh my goodness, penile injection. I can't even imagine injecting myself with a needle. Well, I'll tell you from my experience of injecting over 2,000 men, typically that's the response everybody has. They're really anxious about it until they try it. So we always say, come in, try it out, and then make the determination whether you can do it or not. Because the needle is very, very tiny, goes into the shaft of the penis, and within 10 minutes, you can get a rigid enough erection, hard enough for penetration. So that's typically our next step. Finally, depending upon how against needles you are, or if the needles don't work anymore, if the medication that we inject into the penis doesn't work anymore, there is option for penile prosthesis, but of course there are a lot of risk factors that come with surgery. So that's really our last line if nothing else works. So this is really important because while I said that radiation is, you typically see it down the road, we like to consider radiation as one of the least invasive routes for your erectile function. It's typically, we consider it like a completely nerve spared surgery, even though it does get rid of the nerves. But essentially what I'm alluding to is people typically do well after radiation. They don't have a lot of erectile dysfunction just primarily because of the radiation. What they typically get are from other reasons secondary to that radiation. So the cascade of the radiation plus something else is why we typically see erectile dysfunction. So these are some of the problems. So low testosterone. So any man that's undergone any form of cancer treatment, or just any man in general, should always have a baseline level of what their testosterone is. You need testosterone to support endothelial tissue, to support the blood flow that is supplied to your penis, not just your penis, but your heart, to prevent insulin resistance, diabetes, and also to promote your bone growth and prevent you from fracturing a hip at some point in your life. Another thing that has been shown to cause erectile dysfunction is untreated obstructive sleep apnea. The thought process is that when you're sleeping at nighttime, because you don't go into that deep REM cycle sleep, you're not getting those erections at nighttime that you used to wake up with all the time. And a lot of men don't even realize it until it's pointed out to them. But that's something that should be very, very important for someone that has undergone any form of treatment for their cancers. Metabolic syndrome, high blood pressure, high cholesterol, diabetes are all a huge effect on your erectile function. Your heart is a direct determination of your erectile status. So what does that mean? In a man that has erectile dysfunction for no reason, they didn't have surgery, they didn't have chemotherapy, they didn't have any form of radiation, typically we say, how healthy are you? Because if you have erectile dysfunction, there are huge correlations that erectile dysfunction is a precursor to cardiac heart disease. So it's really important to ensure that you're remaining healthy, eating healthy, exercising. And of course, just getting older is a risk factor for erectile dysfunction as well. Now, to touch a little bit on fertility, I did note that sometimes radiation can prevent you from ejaculating. So you always want a sperm bank prior to radiation. You should always attempt to sperm bank prior to chemotherapy as well, because you don't know if, one, you're not going to be able to produce sperm anymore because of chemotherapy, or two, if the chemotherapy is toxic to the genetic cells of your sperm. So that's two big reasons why. But do know, if you do not sperm bank prior, there are other options. There are a couple procedures that we can do that I'm not going to go too in depth about, but just know that if you were stuck in a situation where potentially you were unable to sperm bank prior to your treatment, that there are other options. As a caveat at the end, I put a retrograde ejaculation because many men think that they're not actually ejaculating, but they're ejaculating back into their bladder. And when you ejaculate into your bladder, there's an easy way to see if you are producing sperm inside your bladder through just analysis, through urine analysis. So we would do that. And if you are, then some of these options, these procedural options, would be something that we could consider. Now, initially, when I first started this slideshow, and I'll go back, I quoted Saving Your Sex Life. This is, and I'm not here to advertise Dr. Mulhall's book, but I do know this was a very, very, very short lecture, and you may have a lot more questions. While Saving Your Sex Life was written by John P. Mulhall, he's my attending. He's a world-renowned attending doctor in sexual dysfunction. He wrote a book for men with prostate cancer, but a lot of it has generic general information that you can go to if you have further questions on the subject matter. And of course, I'm here to take any questions if you have any issues, questions, concerns. And I wanted, again, thank you for having me, and I hope this was helpful for all of you. Take care.